Hi, I'm Dr. Jeffrey Antimarino from Bellissimo Plastic Surgery and Medi Spa. Thank you for joining us for our Facebook Live event. And in the light of October being Breast Cancer Awareness Month, today we're going to be talking to Dr. Sharon Goldstein, who is an oncologic breast surgeon. And Dr. Goldstein and I team up a lot when the patient is a candidate or wants breast reconstruction. So Sharon and I have done a lot of surgery together over the past, and we talked last year. And I want her to kind of go through a lot of fundamental procedures and language so that I think the layman's terms can be understood better, and talk about all the new advances that are occurring not only in breast surgery, but also the treatment of breast cancer early on. So welcome, Dr. Goldstein. It's great to have you.
Thank you very much. Nice to see you again, Dr. Antimarino.
Well, listen, so we were talking just before we started. And so I think what I want to do is take the patients through sort of a virtual, what happens. So most of the time patients will have the diagnosis either because of it's found on a mammogram for screening, or they found a lump, and usually their primary care or their gynecologist sends them to you. What happens from there? Kind of take the patient through what they can expect once they see you, maybe some tests that you run, and then how you assemble the team.
So there are a variety of ways people present. The most common is at the request of their primary care physician or their gynecologist, or perhaps another physician or practitioner that they spoke with about symptoms. The majority of cancers that we see are found through screening mammograms, and we see much smaller cancers when they're found through screening mammograms than when someone has perhaps for whatever reason delayed or not had a mammogram and now they feel something palpable in their breast. If we see the lesion only on a mammogram, we get a mammogram guided needle biopsy. It's a needle where they can remove cells through the bore of the needle. If we can see the lesion on an ultrasound, the radiologist will put the probe right on the breast and put also a small needle into the tumor and remove pieces of the tumor so we can look at it under a microscope and determine if it is benign or malignant. Sometimes the lesion is palpable, sometimes we can see it with our bare eyes. And so there are other ways to biopsy that type of a lesion. Once they see me, I'll examine them. I'll put their films up on the board so we can all see what the imaging looks like, because I really think a picture tells 1,000 words. And I like for the patient to know everything I know. I like for them to see the advantages of the imaging we have, as well as some of the limitations. Sometimes I'll order further imaging. For instance, certain types of cancers, we're more likely to order a breast MRI. And that can give us a really nice look at some of the other tissue and even the other breast, especially in younger women, women with very dense breasts, women with a type of tumor called a lobular carcinoma. At that time, on the first visit, I'll talk to the patient. I'll get a good feel for their family history. We ask a lot of probing questions, so we like people to sort of think this through before they come in. And based on their family and personal history, more often than not, I'm going to order genetic testing. And we work with a couple of companies, and we used to look at two genes, the BRCA genes, BRCA1, BRCA2, the gene that Angelina had a mutation in, Angelina Jolie, right? Everybody knows her. Now we look at about 35 different genes, and some of them cause increased risk of breast cancer, and some of them actually look at other cancers that are commonly found: colon cancer, melanoma, pancreatic cancer, ovarian cancer. There are even some genes that we know about that increase the risk of stomach cancer, gastric cancer, bile duct cancer, other cancers. But we mostly, of course, in my clinic, I'm interested in breast cancer. I'll often order labs before someone has surgery. I look at their liver function tests. We can look at their bone health on some of the blood tests we do, kidneys, that kind of thing. So I will also order a chest x-ray in most women. We want to make sure that their lungs look okay. EKG, depending on the age of the patient. A lot of the workup takes time, which many of our women choose to have a mastectomy, either because the tumor is quite large or for other personal reasons. And a large number of those women will see a plastic surgeon. I actually encourage anyone who's a candidate for reconstruction to at least have a consultation with the plastic surgeon, hear what they have to say. You can show pictures, talk about the way these procedures are carried out. And I always prep them ahead of time. I'll draw diagrams and they have a pretty good idea, hopefully, walking in to see the plastic surgeon. Just because they go, it doesn't mean they have to get reconstruction or even that they're a candidate for reconstruction. But I think women really need to have a full picture of all of their options so they can make the best decision for them.
Right. I think
In
that's
the
one of the
meantime,
biggest.
and this is what you
Good. I mean,
no,
I was
go
just
on.
saying, I think it's one of the biggest advances we've seen in the combination of plastic surgery and breast surgery is that we've been very open and trying to get at least the information to women. And that was not that way, even 10 to 15 years ago. It wasn't, I don't think women had all the options. And you're right. I think women who are candidates, and patients will ask me a lot, who's a candidate, who isn't. But for most part, most women are candidates, but the ones that aren't are usually ladies that have a lot of medical history, and that part of the surgery may be a little too much for them to handle. And so we really just concentrate on the oncologic or the cancer itself. But I think it's a good idea for women at least to have at least an idea of what can be done in an immediate setting, which is what we normally do at the same time as you're doing the mastectomy or delayed. But you're right. And I tell them flat out also is that just because you're hearing it doesn't mean we expect you to do it. We're just giving you the information so you make the best choice for you. So I just wanted to, tell you that, to tell people listening that that's a big advancement, and part of the workup is that all of their options. And so, getting back to you, there's other people that you have them see, and so and kind of go through that with us.
A lot of patients, particularly younger women, will be offered chemotherapy. And more over the last perhaps 10 up to 20 years, we've been giving chemotherapy before surgery. And there are certain advantages to that. And some women are a candidate for that, some are not. Women with very low-grade tumors are really not a great candidate for chemotherapy first because their tumors don't respond very well. So we want to bring them to surgery first. But women with higher grade tumors are a good candidate. So I'll have those patients see oncology. And for some of the women, especially if we're talking about mastectomy with reconstruction, I will have them see radiation oncology because there are certain issues with radiation and reconstruction. And most women, I would say, we don't know if they're going to need radiation up front, but there are a few that we have a very high suspicion for. And so those patients will have radiation. So this workup can take a while. It can take several weeks, actually. And one of the things we will do, and you alluded to it earlier, that we are doing more and more is giving what's called neoadjuvant or upfront hormonal therapy to women who have estrogen receptor positive tumors. Women who have ER positive tumors, which is the majority of women we see, tend to respond very well to blocking estrogen. And there are various medications. Some of the earlier generation medications that we give to premenopausal women are tamoxifen. Tamoxifen blocks the estrogen receptors in the breast. In women who are postmenopausal, we have other options. We can give other medications such as anastrozole, which blocks the formation of estrogen in our peripheral tissues. But either way, if we can block the effect of estrogen, we can shrink the tumors up, making the surgery even easier. Mm-hmm. And we can give the woman peace of mind while she's getting her other opinions.
Once I think that's the important part. I'm sorry. I think that's the important part is now, and I see, and we were talking earlier, I think during COVID, that really became the fashion to if they were receptor positive, and you can find that on the biopsy you were talking about before, as the needle biopsy. But it gives a woman a peace of mind that we're actually treating it early. So in years past, at those 2, 3, 4, 5, 6 weeks of workup, can be anxiety provoking. And now that they know they have a cancer, and so this, I think, really helps them from an anxiety level.
I agree, and it helps us too. And what we're finding more and more with some more newer studies is we can actually see molecular effects in the tumor once we remove it in women who have been on this estrogen blocking medication. So I know we talk a lot about at our multidisciplinary tumor board that we have the Ki-67. That is a proliferation index for tumors. And what we see is women who've even just received a few weeks of tamoxifen or an aromatase inhibitor, they will have a tremendous lowering of their Ki-67. Their proliferation index, the rate at which the tumors are growing, slows down quite dramatically.
Yeah.
And that's good information to have too, because then we can identify people who are going to have a good response to that after surgery. And once
Right.
the tumor's been removed, we've lost that bit of information that we could glean from starting the neoadjuvant endocrine therapy prior to surgery while we're doing our workup. And you're right, you're exactly right. And it's so interesting what's happened during the pandemic. For right at the beginning, I mean, I know you remember this was such a stressful time for everybody. We didn't know whether we could be bringing relatively healthy women into the hospital to operate on them. And we wanted to keep them out of the center. There was a lot we didn't know about the virus. And so the national standard, and this was all over the country as well as all over the world, so we have data from other countries as well, was to stop doing surgery on any woman with ER positive tumors and to put them on this endocrine therapy. And we waited about 3 months on most of these women and more in some. They did well, they did better. So this is really, I think, moving towards what we're going to be doing in the future. And pretty much anyone who's a candidate for this type of medication, I will put them on it at their first visit.
Yeah, and I've noticed that at the tumor boards that we have on Tuesdays, and it's been phenomenal. And I think also, years past, especially when I was first out in practice, we used to get the diagnosis of breast cancer, and we would team up with the breast surgeon, and we would go to the OR within 2 weeks. I mean, it was quick. What we wanted to do was get in there. Because of the anxiety and the stress that the woman knew, we would just figure we would just go in, take care of it. And then by the time afterwards, then let the dust settle and go through everything else. But now this has bought so much better time that we can really, as an oncologic group, you can really study the tumor and attack it even better, and the patients do better than what we did. So just in my career time, the advances of treating breast cancer have tremendously improved. So it's amazing to see, and that's really, this has been the pandemic for, like you said, for as bad as it was, there has been some good things that came out of it, and this, to me, this is one of them, and it's been a huge improvement.
Yeah, I agree with you. It's so interesting to get all this extra information and to collect this data. And thank goodness we're really seeing an improvement in outcomes for women.
Right.
One of the other issues about the pandemic, which I've been asked a lot about, is screening mammography. And this is Breast Cancer Awareness Month. So this is, my plug for getting everyone in to get their mammograms. Early on, we were not doing screening mammograms, and people got delayed, and people missed their scheduled, so they decided, I'll just go next year. And that's generally fine. It's fine for the overwhelming majority of women. So don't feel badly if that's you, if you're the one who missed your mammogram, but please do schedule your screening mammograms. At Excella, we used to have the walk-in Wednesdays, and this was one of our most popular programs. We would get about 70 people a day in the centers, just walking in saying, it's time for my mammogram and I want it. They didn't need a prescription, they could just walk in. So this program is on hold and has been for the whole pandemic. And we're hoping to get back to it at some point, hopefully, in the near future. But in the meantime, you do have to schedule your screening mammograms. We just can't have this many people moving into the health centers and being on top of each other. So please do schedule your screening mammogram.
Yeah, it's amazing what will happen. And we see, I mean, a lot of the patients you and I see together have had multiple mammograms. They're completely normal. And then the next year, they're seeing something early. And so, I tell patients, even when I'm doing other breast surgery, whether it's reductions and lifts and augmentations, if they're in that time frame when they have a mammogram, one of the first questions I ask them is, when was your last mammogram? Or when do you do it again? Because after breast surgery, I don't like them to have a mammogram for about 9 months just because of the post-op changes. And I want the radiologist be able to really look at that after a breast surgery. And so if there's some post-op swelling and inflammation, I don't want that to interfere and them thinking there's something that's there that isn't. So I really am a stickler for it. But it's amazing to me, it's just in 1 year. And I always emphasize the ladies, 1 in 8 women, and that's not the women that have a family history. That's every day, 1 out of 8 develop breast cancer. And we're seeing it. We just talked about a young lady, the other day, and tumor board is, I think it's 27. And I have 3 patients in my practice, over the years that were under 30, and we see them all the way up into their 70s and 80s. So it's all across the board at all ages.
Yeah, it's really something. Something new since we talked last year on this program is incorporating breast ultrasound, whole breast ultrasound, into our screening protocol for women. So up until recently, we didn't have data that showed an increase in good outcomes in women who got screening ultrasound. So all we ever did was diagnostic ultrasound. If we saw something on a mammogram, or if a woman felt a lesion, we would look at that one area with the ultrasound. So now we have a program for women with dense breasts, and we break it into fatty, fibroglandular breasts, or heterogeneously, meaning spotty areas of density, or extremely dense breasts, as women whose breasts are just so hard to image. And we are ordering automated whole breast ultrasound on those women. And that has to be scheduled as well, because it takes a little extra time, but it's actually very quick. It's a plate that sits on the breast, and the technologist just rolls it gently and gets an image of the entire breast that way. And it's a nice screening tool in addition to mammography. And we're hoping, and what the studies have shown, is that over time you can see more subtle changes and increase our pickup rate of very small cancers up to 20 to 30% more. So it's really a good technology. It's only indicated for women with heterogeneously or extremely dense breasts. And when a woman gets her mammogram, she's going to get a letter in the mail telling her if she has dense breasts. So for her next mammogram, she can ask her physician or whoever is prescribing her mammograms to her to order that if she would like.
Yeah, it's fantastic. And so even with the improvements in mammograms and ultrasound alone, the pickup rate for early cancers has improved tremendously. So even at that level, all of that has been so important to pick up early cancers. And so the early is like anything. If the earlier you pick it up, the more likely you have a good, successful outcome, regardless of the age. And so it's amazing. So the question I get a lot, when patients come to see me about possible reconstruction, and sometimes they're set, they're going to do the mastectomy, and sometimes they're still contemplating the lumpectomy, and we talk about it. So talk to us about, what is a lumpectomy? And there's some confusion, I think, with some patients. They think the lumpectomy is just a biopsy, where you go in, make a little incision, take out some tissue, and it's just a further biopsy, but it's not. It's a treatment plan. So kind of go through what a lumpectomy is, and if a woman chooses that, chemo, radiation with that versus somebody who's getting a mastectomy, which is the removal of all the breast tissue?
Mhm, mhm. I'm glad you asked. So a lumpectomy, we call it a segmental mastectomy, meaning we are taking a segment of the breast, is just a removal of the lump or the mass with surrounding normal tissue. So but the word ectomy means removal of, right? So you have your tonsillectomy, your appendectomy, and your lumpectomy. So just means removal of the lump with some surrounding normal tissue. Um, and it depends on the size of the tumor, the type of tumor, whether it's associated with something called DCIS, which tends to have a higher risk for kind of creeping up the ducts because it's just less aggressive. So we will remove the mass, and that's an operation that requires anesthesia. It requires a real incision. It's not a huge incision, but it's a real incision, not just a little tiny incision. And removal of the tissue. And what we do more and more is something called an oncoplastic reconstruction. So, and we learned these techniques from plastic surgery colleagues, and you and I have taken courses and studied this extensively, but it's where we can remove the mass, and then we move tissue into the cavity and to maintain a very nice contour to the breast.
Mhm.
And so all these techniques have improved quite a bit, but that's what a lumpectomy is. When a woman gets a lumpectomy or segmental mastectomy for breast cancer, normally we will talk about radiation therapy. And radiation therapy in younger women, pretty much they all get it. In women 65 and up, 70 and up, we do it on a case-by-case basis. What we know is that in older women and more mature women, there's not so much of an advantage of doing radiation. The risk of the tumor coming back is in a woman over the age of 70 generally approximates something like 70%. And
Mhm.
there are exceptions to that. So women who have ER negative tumors, we are more aggressive about giving radiation even if they're older. Women with larger tumors, women with issues with the lymph nodes in the armpit. But we've really pulled back on the aggressiveness of the treatment, especially in older women. And
Mhm.
what we see is they do better.
Right.
So the less we do, sometimes the better. We have to get rid of the
Right.
tumor. We have to, do certain treatments, but we don't have to do radical surgery in those women. Um,
Mhm.
in women getting a mastectomy, most of them can avoid radiation, but not all of them. Some women who need to get a mastectomy have tumor that's infiltrated in the skin, tumor that's not responsive to chemotherapy or minimally responsive, tumor that is in the lymph nodes in the armpit, tumor that can be next to the muscle. And so those women, even after mastectomy, are at high risk for local recurrence in the tissue itself, and they will be offered radiation therapy.
Yeah, and over the years, even mastectomies have changed tremendously. Where we used to do, longer incisions, and now, depending upon the location of the tumor, the size of the tumor, and the size of the breast, actually as well. There are some things we can do where you can actually save a lot of the skin and just take the nipple with the tissue, and sometimes we can just spare the nipple itself. And you and I have worked, using an incision below, underneath the breast, so the incision's not even really seen, and take out the breast tissue that way, which is a much more of a challenge for the breast surgeon. There's no doubt about it. But from the aesthetic outcome is much improved, and so a lot of these women really benefit again with newer techniques and things that you can do to, again, shrink the tumor down early, and then it might make them a candidate for some of these less invasive mastectomies, because now the tumor is in a much more desirable size and position. So it's tremendous. I mean, from every aspect, this has become a much better playing field for the physicians trying to treat this problem. And just again, in our careers, and we're pretty much in the same career span, but how we used to do it back in the early 2000s versus just a mere 20 years later is tremendously different, and the thought process is different too. So even from the oncologist standpoint, what I'm hearing on the tumor board, it's so much more individualized now, where it used to be, there were 1, 2, 3, types of chemotherapy. Now, depending upon all the studies that are being done, the oncologist can really zero in on certain things, and patients, and what their age and what the tumor really shows. So it's incredible.
It really is. I mean, the oncologists have so many things in their armamentarium. I mean, the immunotherapy, the various kinds of chemotherapy, and it's really terrific what they can do. And I think it's an exciting time for them. They always seem really enthusiastic,
Right.
interested in teaching us and at tumor board.
Yeah. So it's just, but at the end of the day, as you were saying before, it all starts really with constant surveillance. And so you have to be very, religious about it, in a sense. So, get your mammograms, and really see your doctors, and still do your breast exams, because you're the best one to find, something different on your own body, rather than when you see, a checkup once a year, every other year. That physician who may know you still is not going to remember exactly what that breast felt like, a year ago, but the woman will. And so, we're always preaching that. And with all the advancements, everything that we can do now, everything that you do, and so much better, from that standpoint, it all hinges on the woman doing her part at the beginning. And so with all this tremendous advancement, you still need to go and get the mammogram. And I get it, especially as a man. I don't like to, harp on women to get mammograms, because I know that they're uncomfortable. So, it's easy for me to say, hey, you need one, because I've never had one. But there's still the crux of all of this can't be done, until that is completed, or the self exams are completed on a regular basis. What other?
Yeah, I want to give another plug. Actually,
Yeah,
oh, sorry.
that's what I was going to ask you. As we're winding up here, what's another plug that you want to take advantage of?
Yeah, so there's some advances in mammography too. We talked last time about 3D imaging,
Right.
and that's fantastic. But the newest thing we have are these comfort paddles, and instead of it being two rectangular plates just squishing the life out of your breast, we have these comfort paddles that are shaped to a breast, and I've had it now, and they're actually more comfortable. So they're marketed that way, and we have them in all the centers, and they are more comfortable. It's still not, a joyous occasion getting your mammogram, but it is more comfortable. And I will say, for women who can take Advil or Tylenol, some people can't take that for various reasons. I think it really helps I take a couple of Tylenol before I go in, and maybe like an hour before, and it really helps with the comfort of the compression. So that really is a good tip. And for women who are still menstruating, you want to wait until you want to get your mammogram, plan it just at the end or just after you're done with your period, because you know that your breasts are more swollen, they're irritated, they're painful. So don't do it right before a period. It's the most painful time. But those are little tips which actually help quite a bit.
Sure.
But those comfort paddles are terrific. And
Yeah,
I'm
I
glad
didn't even know about those.
Yeah, it's really nice.
Yeah, that's women getting involved now, rather than men designing the machines.
Exactly. Well, and I'll say one more thing about men. Almost 1 in 100 breast cancers are in men. So that's not a lot, but it's enough. And we see breast cancer in men. And I will say, for the men out there and for the women, for your male partners, if you feel something, or if they feel a little lump, they need to get in and see their physician or nurse, someone to really take a feel of their breast. And we will. I know it sounds terrible to you.
I do mammograms.
We will do mammograms on men.
Yeah.
So mammograms, ultrasounds, and that's a good way to differentiate between just benign overgrowth of breast tissue in men versus tumors.
Yeah. Well, listen. Well, thank you so much for talking with us tonight. It's fantastic, and so anything that comes up new, we'll definitely get it out there. But thank you again, and for everybody listening, thank you so much. And we'll continue to bring you some information on breast cancer, especially during this month. So we'll see you next time.
Thank you very much.